right. Well, good evening, everyone. I see by the clock on my computer that it is 6 o'clock. And my name is Janelle DeLemba. I'm the Director of PrimeWise and Volunteer Services at St. Elizabeth Healthcare. And I wish to welcome you to Finding Relief, Treating Chronic Back Pain with Spinal Cord Stimulation. We are very pleased to have all of you join us this evening. This presentation is being recorded. I think that it lets you know that as you entered, but I want you to be aware that it is recorded. And this link will be added to the PrimeWise webpage sometime next week. And we will alert you or email you to let you know when that link is on our webpage. So to that end, I have gone ahead and I am muting everyone except for our presenter and myself this evening. So hopefully you can still hear just fine, but I have gone ahead and muted you. So I am going to ask each and every one of you to please type your name and the name of anyone who might be viewing with you into the chat. That will allow us to capture the attendance and any follow-up, because as we've found out, sometimes the email address doesn't match up to the name of the device that you might be viewing us on. So that's very helpful to us. So you can do so to everyone, or you can do so privately by selecting PrimeWise, which is me, Janelle DeLemba, or Monica, which is Monica Bronwert, and she is our PrimeWise coordinator. So we greatly appreciate it if you would do that. It's likely that you received the newest PrimeWise newsletter, the update in the last couple of weeks. And so there are just a couple of programs that I'd like to highlight in case you did not notice them. October the 12th is Menopause 101, Building the Foundation and Beyond. Dr. Susan Oakley will be providing that, and that also will be a virtual presentation. If you have not had the pleasure of hearing Dr. Oakley before, you may very well be in for a great little surprise. She's very humorous, and you'll learn a lot as well. Then on October the 13th, Medicare, what you need to know before you turn 65. So if anybody who's in this presentation has not yet joined Medicare or become a Medicare beneficiary, but that's in the near future, we strongly encourage you or any of your friends to attend one of our workshops. That also will be virtual. Gives you a great kind of head start on that process. So that will be on the 13th. And then lastly, I'd like to mention a program on the 14th. So we've got on the 12th, 13th, and 14th. If yourself or anybody you know has ringing or buzzing in your ear, I never say this right, but I think it's tinnitus. But we go with the ringing or buzzing in your ear. Then we also will have a presentation and a virtual presentation by ear, nose, throat, and allergy specialist team. And they will follow up with those individuals who do attend the presentation. They will set up free hearing screenings afterwards for those individuals who do participate in that program. So thanks for listening to my PrimeWise commercial. I do appreciate that. Again, kind of a couple of requests for this presentation. Please remain muted, as I already mentioned throughout. We greatly appreciate that. But Dr. Bailey will want to address your questions, so please type them into the chat, and then so that he can answer them at the end of the presentation, any of those that he hasn't answered throughout the presentation. And again, please, if you haven't already, please type your name into that chat box. At this time, it is with great pleasure that I introduce our presenter, Dr. Stephen Bailey. Dr. Bailey is a neurosurgeon with Mayfield Brain and Spine, and he's been serving patients in Kentucky and throughout the tri-state since he joined Mayfield in 2003. He treats a wide range of diseases and disorders of the brain and spine, with particular expertise in spine surgery, including spinal fusion, image-guided neurosurgery, and much, much more, most of which I can't even pronounce. But one of his of special interest and expertise, of course, is the topic that he is addressing this evening: spinal cord stimulation as a method to relieve back pain. Dr. Bailey earned his undergraduate degree from Denison University, and his medical degree from Ohio State University, and completed his residency in neurosurgery at the Medical University of South Carolina. He currently also serves as the medical director of the Mayfield Spine Surgery Center. So at this time, I'd like to turn the program over to Dr. Bailey, and that will take just a moment.
All right, I think we're up. Good evening, and I appreciate the introduction. Again, I'm Dr. Bailey. I'm happy to be talking to you this evening about treating chronic back and spine pain, type of therapy known as spinal cord stimulation. So in the past, chronic back and spine pain has been treated with medications, and that would include opioids, treated with multiple or repeated back surgeries, and some success and some complications and potentially less than desirable results with those. Spinal cord stimulation is a little more recent development and a surgical option that is appropriate for some patients with chronic back pain. There's a difference between acute pain and chronic pain. Obviously, acute pain is what we would typically associate with a known injury frequently, like a lifting injury or maybe an overuse or a fall. Most of the time, acute pain resolves within days to weeks, sometimes involving treatment as simple as modification or rest, sometimes some conservative treatment, very rarely surgical treatment. And as the injury heals, the pain subsides. And typically the pain in an acute injury like that is related to tissue injury. Chronic pain is what we describe more recurrent pain, frequently daily or continuous, that's been going on months or longer. Typically that's long after any type of associated injury, if there is one, has healed. Frequently been treatments of various kinds, surgical potentially, and certainly non-surgical. Pain persists despite that. The psychological or emotional aspects of that also contribute to the pain. And the pain in chronic pain can be due to degenerative changes to joints, portions of the spine, and even degenerative or injuries to nerves themselves. Pain is a very individualized experience. It's difficult to relate necessarily to someone else's pain and vice versa. We try to use a scale, 0 or 1 to 10. But even with a scale like that, one patient's 10 out of 10 may allow them to continue to work and function daily, whereas another patient's 4 out of 10 prevents them from working. And when you combine that with depression, anxiety, lack of sleep, it becomes even more complicated than just a simple number. Chronic pain can arise from a musculoskeletal origin, so that would be such as a degenerative joint or a degenerative area of the spine. That is a major component of chronic pain. There's another component of chronic pain, which is neuropathic pain. That's pain generated either by a injured or damaged nerve sending signals to the brain, or perhaps even the abnormal interpretation of signals by the nervous system that's perceived as pain. Typically, the musculoskeletal pain is more of a throbbing or aching and can often be localized to an area of the body. The neuropathic pain is frequently described as numbness, tingling, or burning type pain and can cover a larger area of the body. Pain cycle has both a physical and a psychological component. Emotionally, anxiety, stress, depression can all feed back and increase pain. And similarly, the physical component, avoiding activity, conditioning or becoming weaker, poor sleep, and then all that contributes to more discomfort in the day-to-day life and the activities of daily living. Clearly, there's a cost to chronic pain. A cost to the individual is obvious, to family members as well. Cost to society and employers, and even a huge cost to the healthcare system. Chronic pain is treated like a lot of conditions with conservative options and therapies first. Medicines, anti-inflammatories, perhaps pain medications, physical therapy, chiropractic manipulation. Those means are unsuccessful. Somewhat more invasive options include injections, nerve blocks. When those therapies are exhausted without success, that's when we could consider surgical treatment of chronic pain. So many patients who have developed chronic spine or back pain have had one or more spinal surgeries, and many of them might be considering another. While each case is different, we frequently find it's a situation of diminishing returns with surgeries, that subsequent surgeries have a lower likelihood of success and sometimes even a higher likelihood of complications. That brings us to tonight's topic, spinal cord stimulation, option for some in chronic pain. This is a picture of a patient we're looking at from the back. Area of pain here is indicated in red in the low back, kind of in the left buttock and sciatic area. This is also a patient who has a spinal cord stimulator in place. We'll look at this a little further, but there's three main components to a spinal cord stimulator. Top is the lead or the electrodes. That's where the actual stimulation or electrical signals to the spinal cord occur. There's a wire that connects from the leads down to called a pulse generator, which is basically a battery or power source that provides a stimulation. It controls programs, stores the energy for the system. Well, the goal, of course, of spinal cord stimulation in chronic pain is pain relief, not necessarily resolution of the chronic pain, but improvement in the pain and hopefully improvement in function and quality of life, day-to-day life. But very frequently that pain relief is achieved by creating what we call paresthesias. Paresthesias are a sensation that a patient experiences, sometimes described as numbness or tingling or buzzing. But the stimulator produces these paresthesias in an area of the body that overlaps with the pain. And it's those signals, those paresthesias, that block pain signals from the back, from the leg, from reaching the spine and being interpreted as pain. So spinal cord stimulation is an option for some patients with chronic pain. Typically, those patients have gone through the spectrum of care, beginning with more conservative measures first, and those have been unsuccessful. Typically, we like to evaluate for any surgically correctable problem, something straightforward like a herniated disc. I still have patients referred to me for spinal cord stimulators who have fairly textbook lumbar stenosis and symptoms that arise from that, and almost always directly treating that condition is a better option than spinal cord stimulation. But there are definitely patients who've had spinal surgery, might be considering a more extensive surgery, more complex operation, and spinal cord stimulation might be a viable alternative to that. We routinely perform this type of surgery on patients 60, 70, even 80 years old. So generally, we can accommodate most medical conditions, although occasionally we do have a patient who's just medically not sound enough to undergo a procedure like this. And then absolutely any confounding conditions, depression, drug addiction, those are typically picked up during a neuropsychological evaluation before the surgery, and that requires treatment before proceeding. And then lastly, and possibly most important, every patient for whom spinal cord stimulation is considered as a long-term option, they all go through a spinal cord stimulator trial, and hopefully a successful one. I mentioned earlier that the pain relief comes from generating paresthesias in an area of the body. This little line graph shows frequency of stimulation on the bottom. And for many, many years, that's how all spinal cord stimulators worked, or the vast majority, by creating these paresthesias at these lower frequencies of stimulation. More recently, there's experience with much higher frequencies of stimulation. And at these higher frequencies, patients don't feel paresthesias. So there's a couple advantages to that. The biggest advantage is to achieve pain relief in the paresthesia-based stimulation. It requires stimulation in the area of the body where pain is being experienced. So, for example, a patient who has pain in the left leg and a great deal of pain down below the knee or in the foot, if the stimulator only produces paresthesias up in the lower back or the hips, or mostly on the right side, but not down in the left foot or left leg, very unlikely that patient's going to experience any benefit from that stimulation. That limitation is really not a concern with the high frequency stimulation. There are rare cases or patients who experience some shocking sensations with a paresthesia-based system, usually when they're changing from one position to another. That's also not a concern with the high frequency stimulation. There's a few different brands of stimulators out there. There's a great deal of overlap, but some unique characteristics of each of them. The diagram we looked at earlier showed the three parts of a spinal cord stimulator that are implanted or internalized in a patient. There are a couple components that are external. Here on the left is the patient controller or the patient remote. That allows a patient to turn the system on and off, increase the intensity, and even change between programs. And next to that is a charger, which is used to charge the pulse generator, which are frequently rechargeable nowadays. I mentioned also earlier a spinal cord stimulator trial. Some patients or physicians call that a test drive. It's basically a period where a temporary stimulator is placed and a patient gets to experience that stimulation over a period of days. to decide whether or not it's helpful in relieving their pain. So to place a spinal cord stimulator trial is what I describe as a procedure very similar to having an epidural steroid injection. Many patients in this situation have had those. Down here on the right, we see such a procedure being performed. There's a patient awake, but laying on their stomach with the use of an X-ray machine and a hollow needle. That stimulator wire can be introduced into the spinal canal, into the epidural space. And that's how those leads are placed. So here's a couple pictures representing that procedure I've described. So on the right, again, we're looking at a patient's back. You can see a couple needles here that are going through some anesthetized or numbed areas of the skin in the back. They're entering into the spinal canal, and then you can see wires being passed through those needles, and the electrodes at the other end of those wires are up in the lower thoracic portion of the spine. So, and that's very typical positioning and location. So even with this patient here shown with the pain in the red, pain down in the low back and the sciatic area, the stimulation actually occurs up here in the lower portion of the thoracic spine in order to achieve pain relief in that area. This middle picture is an X-ray. It's a front to back view X-ray of that procedure being performed. You can see two needles. This needle on the right has a wire passing through it, and you can see it very faintly extending up beyond the top of the X-ray. And then over here on the left, there's a wire into the needle, and you can actually see the electrode starting to emerge from the needle down here in the spinal canal. And then lastly, here on the left is a drawing. This is a side view of the spine where this procedure is being performed, and it shows the relevant anatomy. These squarular areas here that are numbered represent the vertebrae. This yellow column here is actually the spinal cord itself. And then the brown areas are what we call the epidural space. The epidural space is inside the spinal canal, but outside the spinal sac and outside the spinal cord. That's where these electrodes are placed in the epidural space on the back side of the spinal cord. Here's a video of a physician, one of my colleagues, placing an electrode for a spinal cord stimulator trial. You can see on the monitor there the electrodes being advanced through that needle into the epidural space. It can be steered there with the physician's right hand and then advanced with the left hand. The video skipped an important step of when the leads are in the desired location. They're turned on to make sure the paresthesias are in the proper area. The leads can be advanced or repositioned as needed. And then they are, once they're in a satisfactory location, the needles are withdrawn, and those electrodes are then anchored or secured to the skin with stitches, connected up to those thicker white wires you saw, and then connected here, as this drawing shows, to a external pulse generator that's worn on the belt. So the leads are internal, but they exit through the skin, and then the programming system, the power system, is external. So typically a patient will use this system for half to a full week and then track their pain during that time. So that brings us to the spinal cord stimulator surgery, or the permanent implantation. That's where someone like myself, a neurosurgeon, spine surgeon, that's where we typically get involved. This is a picture we saw earlier, again, with the three components of the spinal cord stimulator, the electrodes up in the lower thoracic spine, again, also treating pain in the lower back, and then the wires which would run under the skin to the battery source, also implanted under the skin. So there's some variation in how these procedures are performed from system to system, and even from physician to physician. But a very common way that spinal cord stimulator surgery is performed would be in an operating room. Prior to surgery, I will typically consult with the patient to mark an area on one side of the lower back or the other, and that's where we will place that battery source or pulse generator. Often we perform this surgery under an IV type of anesthetic, where a patient is put to sleep but able to wake up and converse with us during the procedure. We do that to be able to confirm the results of our stimulation. So when we head back to the operating room, our patient is comfortably positioned on their stomach, allowed to slumber, and then we set up our surgical field as we did here. We plan and make our surgical incision and make a laminectomy to allow access into the epidural space or the spinal canal. Using X-ray, we can position the electrodes. And at that point, we then wake our patient up. We test the system. We make sure we're achieving the paresthesias or stimulation in the areas we want. Adjustments can be made at that point, right, left, up, or down. And then once we're in a satisfactory location, the leads are anchored or secured to keep them in position. We allow our patient to go back to sleep. We then open our second incision for the battery or pulse generator. The wires are run under the skin and then connected to the pulse generator. At that point, if we close both those incisions, that entire device I've described has then been implanted, and it's all internal. This diagram shows the two incisions I've described. The upper incision here over the spine is where the laminectomy is made and the leads are inserted. The lower incision here is where the pulse generator or battery, as it's sometimes called, is placed. To the right here is a picture of a surgical spinal cord stimulator lead. You can see it's a little wider than just a simple wire, too big, of course, to pass through a needle, and that's the reason the laminectomy is performed. This diagram points out what a laminectomy is, a very common spinal procedure, probably the most common spinal procedure performed. In green here is a portion of the lamina and spinal process, and part of that is removed to allow access into the epidural space to place those leads. Here's our picture yet again of the device in place. Another look at the lead itself down here on the right. And again, a diagram here on the left. We're looking at a view from the back of the spine. Here on the right portion is probably what would be considered a unrealistically small laminectomy, but a laminectomy to allow the leads to be inserted up into the epidural space on top of the spinal cord. And again, here's a picture, a drawing from the side. This is the patient's front up here with the numbered vertebrae. The epidural space is in magenta, spinal cord in yellow, and you can see the leads entering into the spinal canal, into the epidural space through a laminectomy here, and then sitting on the back side of the spinal cord. Here's a couple intraoperative x-rays on the left before the lead is placed, and in fact, before the laminectomy is made. And then over here on the right, we can see the spinal cord stimulator electrodes in position. Down here at the bottom where it says T12 in this brighter area, that's actually the incision and the laminectomy. So almost always this spinal cord stimulator surgery can be done safely as an outpatient, meaning patients can go home the same day, sleep in their own bed. There are some typical activity restrictions you'd see with a laminectomy, a brief period of no driving, avoiding strenuous activity, heavy lifting, etc. More specific to the stimulator itself, we ask patients to avoid activities like bending, reaching, twisting, lifting, things that stretch out your middle and lower back. Those kind of movements can put tension on those wires we saw. And with tension, that can pull those electrodes out of position potentially. If those leads get pulled out of their proper position, unfortunately, they're not going to go back into position on their own. That would require an intervention to do that. And usually we ask patients not to concern themselves too much with using the system, charging the battery or anything like that for the first 2 weeks. Let things heal. And then at the first postoperative visit, we turn our focus then to using the system. The potential complications of this type of surgery include the complications of any laminectomy, bleeding, infection, spinal fluid leak. I talked about leads migrating or being pulled out of position, and that very often can have a negative impact on stimulation, can require another surgery. Fortunately, we have very good compliance with patients, and that's a very, very infrequent occurrence. Similarly, problems with the system itself, a lead that breaks or fractures, a problem with the battery, those are also very, very infrequent occurrences. Realistic expectations are really crucial to success, and without a doubt, the best predictor of success for spinal cord stimulation would be the trial. So patients who experience good relief during the trial, 50% or more, every reason to believe that they will have a successful experience with a permanent implant. So substantial pain relief is definitely a goal and a realistic one. 100% pain relief in most cases is probably a little optimistic or unrealistic. Improvement in quality of life, functional abilities day to day, I think is very reasonable and realistic, as well as reducing one's requirement for pain medication. All right, do we have any questions? There we go.
I didn't see any questions. Did you, Dr. Bailey?
Yeah, I've been able to bring those up.
Good.
Please feel free, type in question. I'll do my absolute best to answer it for you.
So Maureen says, what about swimming?
I assume that means, is that an acceptable activity at some point after surgery? And yes, I described a period of time where we have those additional activity restrictions to avoid the leads migrating or being pulled out of position. Fortunately, after that period of time, your body does a very good job of forming scar tissue, and that, in effect, does a great job of keeping those leads in position. So people get back to very, very active lifestyles. I would not anticipate anybody having an issue swimming as long as they're able to swim beforehand.
And please, we encourage you to type in another question or two. And as a reminder, there's about 3 or 4 of our participants who have not shared their name in the chat, and you can do so privately by addressing that to PrimeWise or to Monica. But please, well, we've got the expert here. Let's ask him a couple of questions. I can assure you, if this was in person, they'd be lining up.
And that's fine. I'm always available to ask questions in the office or even outside.
All right. Well, okay. Maureen also asked another question. Would this block permit me to do something harmful?
I think I understand that question. Would pain relief allow you to do something that would injure yourself or injure your spine? Is that what we're asking? Well, so this would not be like an anesthetic that would make an area of your body numb, where you could potentially fall and damage your knee and not be aware of it. Now, something like that I have not seen. All right.
And you might be able to see the question from Peggy Wells.
Yes. We do use spinal cord stimulation sometimes in patients who've been treated for scoliosis. I think we'd have to kind of review your history and discuss your pain and in your experience so far with your spine face to face to make that determination. But scoliosis would be a condition or a condition of pain that is treated successfully with spinal cord stimulation.
All right. Well, on behalf of PrimeWise and all of our members participating, I thank you, Dr. Bailey, for very interesting and for those individuals suffering with back pain, I'm sure a very enlightening presentation. I particularly was interested in that there's that little trial that you can do. That's always a good thing. So to everyone who's participating, we do request your feedback and we really do need your input. So please look for an email from PrimeWise tomorrow. We'll have a SurveyMonkey link. That's our evaluation. So it's very important to us that you go ahead and click on that link and take that survey, please. Additionally, we will send you an email when the presentation link for this presentation is made available on our webpage, so you can share that with other friends of yours as well. Thank you greatly. Anything else, Dr. Bailey?
No, I think we covered it.
Here's one more. How do you go about getting the trial procedure?
I think we'll have some contact information probably either at the end of this presentation or that can be distributed. But Mayfield Brain and Spine can can help with that. Absolutely.
So absolutely. So in the email that we send to you with the survey, we can certainly put Dr. Bailey's contact information in that email that we send to each one of you with our Survey Monkey, our evaluation. Would that work for you?
Yes.
Great. And I think there's one more that I see here. I have degenerative discs in the T cells area pushing on the nerves. Will this work?
Again, a specific case, specific individual. I think those are best reviewed face to face, with a consultation. But pain from degenerative disc disease would definitely fall under a group of conditions that are treated successfully with spinal cord stimulation.
How long after the trial can you have the permanent procedure?
Typically that occurs over probably a couple weeks. There's many patients who, when they've had a particularly successful trial, are very, very eager to get that done, understandably. But typically we're talking on the order of weeks, a couple weeks, not a prolonged period of time.
Well, thank you, Dr. Bailey. Thank you to all of our participants and for your great questions. And have a good rest of your evening here.
Thank you.